You're watching the Wellness Hour, the leader in medical news and information. I'm Randy Alvarez. Today's topic, new treatment options for people that have been diagnosed with cancer. With us, we have two radiation oncologists, Dr. Ted Masek and Dr. Greenberg. Doctors, welcome to the program.
Thanks for having us.
Now, Dr. Masek, we've had you on the program before, so we'll start with you. And for people that don't know what a radiation oncologist is, tell us.
Radiation oncologist is a doctor who's gone through medical school, internship, and residency, and specialized in treating patients with cancer with radiation. They're one of the three main groups that treat cancer: surgeons, medical oncologists, and radiation oncologists.
Now, Dr. Greenberg, you just left, I guess, Desert Hospital to join the team.
Correct, yeah. I've been in the desert now 15 years, and my partner here, Dr. Masek,
About 18.
about 18 years now.
Now, is it true, by the way? I mean, you're the most experienced radiation oncologist in the desert?
That's
Is that
us.
fair to say?
It's very accurate.
That's true.
We've, Randy, we've been in friendly competition for the last 15 years.
You two
Yes,
have.
Peter and I.
Okay.
And it's been a great relationship. Every innovation in radiation oncology that has been brought to the desert in the last 15 years has either been done by Peter or I.
Dr. Masek, you were the first in the desert to have that trilogy.
Yes, the trilogy is a machine that allows us to treat cancer with every form of radiation: IMRT, stereotactic radiosurgery of both the brain and the body, and also to do something called respiratory gating.
Okay, now as far as options go, because today's program is about options, somebody's been diagnosed with cancer, where do you stack up as far as the desert with options for patients? I mean, are you
Great
leaders?
options. We're leaders. I mean, one of the nice things about the desert is we've had the ability to provide patients with terrific options for treating their cancer, so they don't have to go other places to get cancer treatment. And one of the nice things now, particularly with what we've got going on, is the latest option we're bringing on is tomotherapy.
Isn't it true, though, that the hospitals have more radiation options for cancer patients than you do?
Actually, we've got
Or it's
more.
not true?
Yeah, Randy, we've got more radiation options than the hospitals have.
Okay.
We've got both the trilogy machine that Ted has already referred to. We've got the respiratory gating, which the hospitals don't have at this point for treating lung cancer patients. Plus, we're putting in tomotherapy, which is the newest option that's going to be available to patients out here in the desert, and that's something the hospitals don't have.
Okay.
And what that means, the respiratory gating and the stereotactic radiosurgery, 6 months ago when I would treat somebody with early stage lung cancer, I might have a 20% chance of controlling that. I've increased that with stereotactic radiosurgery to 85 to 90% chance of controlling those patients, and we can give all the treatment in 3 to 5 fractions now.
So the newest thing then in the treatment of cancer therapy when it comes to radiation is this tomotherapy?
It's a great advance. I mean, it's a type of machine that's designed to put high energy radiation beams into tumors and give very little dose to the surrounding tissues.
Let's begin with early diagnosis. Somebody's been diagnosed with cancer. Who does the diagnosis, and then when do you get the referral?
Generally, the diagnosis is going to be done by a surgeon, although sometimes a breast cancer patient may be diagnosed by a mammographer with a needle biopsy. So the patient's going to come to us either through the surgeon, might come to us from the medical oncologist, a urologist if it's a prostate cancer patient. So those patients come to us already with a known cancer diagnosis.
What kind of cancers are you treating at your center?
Randy, over 50% of the patients that are diagnosed with cancer will get radiation at some point. So we're treating rectal cancers, colon cancers, lung cancers, breast cancers, cancers of the brain.
Prostate cancer as well?
Oh, absolutely, prostate cancer. We do a large volume of prostate cancers.
Okay, so now we're talking about two therapies today. We're talking about this stereotactic radiosurgery and this tomotherapy. Is that correct? Two different machines. They target the tumor, and I guess the goal is to not damage the surrounding tissue.
Exactly. I mean, the goal with all these treatments is where we've gotten so much better than we used to be is two ways. One, we can identify the tumor much better. I mean, we can find the target better than we ever used to be able to do, number one.
Okay.
Number two, we can get the radiation beams into those tumors and skirt around the normal tissues in the body. For instance, if you're going after some tumor in the middle of the abdomen, you've got the kidneys to work with, the liver, you've got the bowels, the stomach, and we could aim radiation beams in multiple different directions to miss the sensitive structures and get to the middle, say, where maybe the pancreas is.
Okay.
And in the past, when we tried to treat those types of tumors, these patients would get quite ill. Now we can sneak the radiation into these areas and do the treatment much more
Are
easily.
your cure rates better now than they were 10 years ago? Are they that much better?
I think so. The studies have showed there's actually less cancer deaths in the country from people with cancer than before. That's in a population that's growing. So yes, we're doing a much better job in controlling tumors.
Okay, go ahead. And you were going to
But
say.
I was going to say, one good example, Peter, I think, is our head and neck patients. In the old days, when we would treat head and neck cancers, by necessity, we'd have to treat the salivary glands. And that means sometimes those patients couldn't taste their food, they couldn't swallow, their mouth was completely dry. Our patients now with IMRT usually swallow very, very well, have a wet mouth, and are able to function as normal.
Okay, Dr. Greenberg, you told me in the green room, and you said when you were at the hospital, when you were working at the hospital, oftentimes you would have to send these people maybe to Loma Linda, City of Hope, to get things like tomotherapy. Is that right?
Yeah, and what we do now is we're going to have...
did you do that? Did you have to do that?
I mean, Loma Linda University has a proton machine, which we talked about, which is a specialized form of radiation therapy that's only available in a few parts of the country. Now with us having the Trilogy machine, the tomotherapy machine, being able to do stereotactic treatments for brain, for body, we've got the ability to really provide just about every sort of treatment the patients might need at our various centers that are going to be located throughout the desert so that the patients don't have to travel.
So you're 21st century oncology. It's just the both of you. Are there advantages over the hospital? What does the public need to know? I mean, look, you've been diagnosed with cancer. It's a tough time.
Sure.
And I guess, are they going to get better service because you're smaller? Are they going, do they have to wait less?
Actually, the good thing about 21st Century is that it's a large company.
Okay.
And what that allows us to do is allows us to bring the university technology to the community so patients don't have to drive very far. We have over 80 or 90 centers throughout the country. It has an unbelievable infrastructure for physics and help and allows us to bring these high-tech treatments to the patients in the community.
And we've got the ability at our centers to provide very personalized service for patients in a patient-friendly environment, and yet at the same time we're providing this very high-tech university-style technology for patients that previously they'd have to go for tomotherapy, for example, to City of Hope, which is in Duarte, which is a couple hours away from where we practice.
And people are doing that today, though.
People are doing that
in the desert. They don't realize you're there.
And now,
is that going on?
Correct.
That's true. Yeah.
And now we're here. We've got it.
Yeah, I'd also like to mention what type of a company 21st Century is.
Okay.
We believe that everybody, no matter whether they have the financial means, should get treated. So we take all insurances at our department, whether it's Medi-Cal, Medicare, or whatever. Even if you don't have insurance, we will treat you.
Okay, so if somebody, let's say that they've been diagnosed, they're with cancer, they're about to go to the hospital for their radiation oncologist, should they get a second opinion on something like this? I mean, can they? And can they switch? I mean, do they need a referral from their treating physician to see you?
I feel very strongly that there's you can't get too many second opinions. When somebody asks me, should they get a second opinion, I tell them you should get as many opinions until you feel comfortable with your treatment. So if you have been diagnosed with cancer and you're ready to start your fight, give us a call. Okay,
so they could go in and they will see one of you. Now, you're also referred to as the dream team. That means that, and correct me if I'm wrong, they're saying that you have the most experience of any radiation oncologist in the desert. Is that true?
It's true.
Because if it's true, if somebody has cancer, they should request to see the people with the most experience. But don't the machines do all the work? Or is that, does your experience?
Listen, you need both. I mean, the machines are very important.
Okay.
I mean, with radiation oncology, you need two things. You've got to have the best technology. That's very important. But you have to have the experience to have used the technology, to know how to use it, to know what it's capable of, to know when to use which technology, and when it's appropriate for the different types of tumors. And because, as Dr. Masek was saying, we treat tumors in the head and neck, the lung, the stomach, the pancreas, the rectum, the prostate, you've got to be able to decide when you've got a certain type of tumor, which machine is it better for? Because we've got the tomotherapy machine. Which machine do you put the patient on? The Trilogy, the tomotherapy machine? You've got to know what's the right time, and you've got all this technology to use, and you've got to make the right decision right up front.
Let me tell you something about my friend here, Peter.
Okay.
All right. Okay. Both Peter and I have been doing seed implants for prostate cancer for the last 10 years. All right. When you have prostate cancer and you're going to have seeds placed in there, you want to go to somebody who's doing 5 or 10 a month, not 5 or 10 a year. You know, anybody can miss a nail with a hammer, but the carpenter that does it every day is much less likely to miss it. And Peter has as much experience as anybody in Southern California doing this. So do I.
Then let's begin with the newest, tomotherapy. What type of cancer is it for? Does it work best for? And how does it work?
Well, tomotherapy is like in diagnostic radiology having a CT scanner and an MRI. With Tomo and Trilogy, some cancers can be treated better on tomotherapy, and some cancers can be treated better on the Trilogy system with SRS. Peter, don't you agree that most head and necks should be treated on the tomotherapy?
Oh, absolutely. I mean, with the tomotherapy, you've got the ability to really...
So brain tumors, things like that?
Brain tumors,
those type of cancers?
Brain tumors we might treat on the Trilogy,
okay.
But head and neck cancers such as the base of the tongue, oral tongue,
I see.
tonsil, larynx, we're going to treat those on the tomotherapy machine.
And the reason is that we're able to treat right around the salivary glands and prevent side effects.